Assalamu alaikum. This is the presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is chronic suppurative otitis media Atticoantral type or Atticoantral CSOM. Introduction. Atticoantral CSOM is basically a squamosal type of disease of the middle ear cleft, and in contrast to the tubotympanic disease, which involves the anteroinferior part, it mainly involves the posterior part of the middle ear cleft. It is associated with Cholestatoma. It is an unsafe type because of its bone eroding properties, and due to which there is high risk of serious complications. Atticoantral disease is associated with an attic or marginal perforation. So if we see in this picture, this is the normal eardrum, this is pars tensa, and this is pars flaccida or the attic region. And in this picture you see the pars tensa is intact, but there is a big hole or perforation with Cholestatoma in the pars flaccida. So pathogenesis for Atticoantral disease, number one is the Cholestatoma. So it should be understood that Cholestatoma is not a separate disease or diagnosis. It is basically the pathology, underlying pathology in Atticoantral disease. We will discuss Cholestatoma in detail in upcoming slides. Then the osteitis and the granulation tissue. Osteitis, it involves the outer attic wall and the posterior margin of the tympanic ring. A mass of granulation tissue surrounds the osteitis and may even fill the attic, antrum, posterior tympanum and the mastoid. These granulations, they may appear in the form of a fleshy red polyp. Then is the ossicular necrosis. It is common in the Atticoantral disease. Destruction may be limited only to the long process of incus, which is the first ossicle to be involved, but as the mass expands, it destroys or involves the handle of malleus and even the entire ossicular chain, and it get in place of these ossicles and help to conduce the sound from the tympanic membrane to the stapes footplate and to the inner ear. So these are the Claustratoma hearers. We will again discuss this in the symptoms. Then cholesterol granuloma. It is a mass of the granulation tissue with foreign body giant cells with surrounding cholesterol crystals. It may present in the mesotympanum behind an intact eardrum. In such cases, the eardrum may appear blue. It may present along with Cholestatoma or may present as a separate entity. So what is Cholestatoma? Cholestatoma, it is basically a misnomer, as it's neither a tumor nor does it contain any cholesterol. Hence, it can also be known as epidermosis or keratoma. Roughly, it is said to be a skin in the wrong place. As already mentioned, it is a squamosal, meaning the squamous epithelium in the mucosa, squamosal type of disease. So when contains the squamous epithelium. So it is the skin in the wrong place. Skin is present on the outer side of the tympanic membrane. So when it is present in the middle ear behind the eardrum, then this is not the place for the epithelial surface. So it will give rise to Cholestatoma. So a Cholestatoma is a sac or pocket in the middle ear cleft lined by keratinized squamous epithelium and contains desquamated keratin sheets in concentric circles and has bone eroding properties. A very simple definition is epithelial lined cavity containing the keratin debris. This is a simple definition. So what does the Cholestatoma it consists of? It basically consists of two parts. the matrix and the central white mass. The matrix is made up of the keratinizing squamous epithelium resting on a thin fibrous stroma, while the central white mass, it consists of the keratin debris which is produced by the matrix. The exact formation of cholestatoma is not known, but there are different theories which show the formation of cholestatoma. So, number one is the Corner's theory. This is basically the presence of the congenital rest cells. It arises from the embryonic epithelial cell nest outside the middle ear cleft in the temporal bone or the frontal bone or other surrounding bony structures. Then the Whitmax theory, the invagination of the tympanic membrane from the attic or the posterior superior part of the pars tensa in the form of retraction pockets. So, in the retraction pocket, as I already mentioned, the outer surface of the tympanic membrane, which is lined by the stratified squamous epithelium, and once it invaginate, it forms a matrix of cholestatoma and it lays down keratin in that pocket, and this pocket is totally closed and it becomes a mass behind the ear, in the middle ear cleft behind the pars flaccida. Other theory is the Reudi's theory or the basal cell hyperplasia. The basal cells of the germinal layer of the skin, it proliferate under the influence of infection. So, due to irritation like otitis externa or trauma, continuous scratching, the basal cells of the germinal layers of the skin, they proliferate, and keratinized squamous epithelium, it immigrate into the submucosal layers, and then it forms the Claustratoma. Sadis theory is that the middle ear mucosa, like respiratory mucosa elsewhere, undergoes metaplasia due to repeated infections, and this repeated infection then transform into the squamous epithelium. And Haberman's theory is that the epithelium from the meatus or the outer drum surface, it grows into the middle ear through a pre-existing perforation. In retraction pocket theory, there is not an already present perforation, but the pocket, it invaginates so much so that the neck, it closes and it becomes a mass behind the eardrum. But in epithelial invasion theory, there is a pre-existing perforation, and the epithelium, it migrates from either the external-auditory meatus or the outer surface of the eardrum into the middle ear, and thus it may lead to formation of the cholestatoma. So, classification of Claustratoma. Claustratoma is basically of three types, or rather two types, congenital and acquired is further subclassified into primary acquired and the secondary acquired. The congenital Claustratoma is defined as a pearly white lesion behind an intact tympanic membrane. It is basically incidental finding, or the patient may present with hearing problem, but there is no history of discharge, and you will see a white mass behind an intact eardrum. It arises from the embryonic cell rest in the middle ear cleft or the temporal bone. It occurs at three important sites. One in the middle ear, in which it appears as a mass behind an intact eardrum, petrous apex, and the cerebellopontine angle. Symptomatology, it depends on its location. So, in this picture you can see this is the handle of malleus, this is the pars tensa, and there is a white mass behind the intact eardrum. As already mentioned, presents as a white mass behind an intact tympanic membrane. So, a mass is there, so it will affect the conduction, so causing conductive hearing loss. It may rupture spontaneously through the tympanic membrane and presents with a discharging ear, and in such cases it will be indistinguishable from the chronic suppurative otitis media. It can be discovered on routine examination of the ear. Acquired, primary acquired. In primary acquired, there is no previous history of otitis media or pre-existing perforation. So in this, the invagination theory of the pars flaccida, in which the retraction pockets they are formed, can be there. But how these retraction pockets occur? The persistent negative pressure, okay, the pressure is maintained by eustachian tube. So chronic eustachian tube problems, it will lead to all these problems. So persistent negative pressure in the attic causes a retraction pocket. You see here the pocket is there, okay, which accumulates the keratin debris, and once it gets infected, the keratin mass expands towards the middle ear. It will expand behind. The other theory is the basal cell hyperplasia, that the subclinical infection of the childhood induces basal cells of the pars flaccida to grow inward and form a Cholestatoma. You see this area, it should be all covered with bone, but it is now the pocket is there. So this Cholestatoma, which ultimately breaks through the pars flaccida, forming an attic perforation. Secondary acquired Cholestatoma. In these cases, there is a already or pre-existing perforation in the pars tensa. This is often associated with the posterior marginal perforation or sometimes large central perforations. Theories which lead to the formation of the secondary acquired Cholestatoma is the migration theory. The keratinizing squamous epithelium, as already mentioned, from the external aortic canal or outer surface of the tympanic membrane, it migrates through the perforation into the middle ear. Perforations which involves the tympanic annulus are more likely to allow the ingrowth of squamous epithelium. The second theory is the metaplasia, in which the middle ear mucosa, it undergoes metaplasia due to repeated infections of the middle ear through the pre-existing perforation. So in the picture, this is the secondary acquired Cholestatoma, which is seen through the perforation of the tympanic membrane. How does a Cholestatoma it expand and erode? Once the Cholestatoma it enters the middle ear cleft, it invades the surrounding structures, first by following the path of least resistance and then by the enzymatic bone destruction. An attic Cholestatoma, it may extend backwards into the adductus. Just visualize the picture of the middle ear cleft. So from the attic it will go into the adductus, then into the antrum and the mastoid ear cells. Then downwards it can affect into the or lead into the mesotympanum, while medially it may surround the incus or head of malleus and these ossicles. So Cholestatoma, it may cause destruction of the ear ossicles, erosion of the bony labyrinth, the canal of the facial nerve, sinus plate of tegment tympani, which is a separating bone from the brain, middle cranial fossa, and thus it causes several complications, serious complications. So the destruction by Cholestatoma, it is presented by an enzymatic theory in which various enzymes like collagenase, acid phosphatase and proteolytic enzymes, they are considered to cause the bone destruction by Cholestatoma. These are produced by the perimatrix, osteoclast and the mononuclear inflammatory cells seen in association with Cholestatoma. And so this is the most preferred theory which shows how the Cholestatoma it causes destruction and expansion into the surrounding structures. So in this picture you can see there the pocket or the retraction pocket which contains the skin cells. It invaginate, and this early Cholestatoma cyst, it forms in these pockets, and once the negative pressure, if it is continuous, so this retraction pocket, it becomes a mass and later on give rise to the Cholestatoma, which grows into, at first it is more likely to grow and destroy the structures in the middle ear, and as the time goes it may erode and damage the structures in the inner ear or even erode the bone, tegment tympani as already mentioned, of the skull and enter into the brain, leading to complications. Symptoms. As already mentioned, the main symptom of chronic suppurative otitis media is the ear discharge and hearing loss. But the ear discharge of Atticoantral is different from that of the tubertympanic disease. So history is very important regarding the discharge. Discharge is usually scanty. Sometimes it is so less that patient may not be completely aware of it. And secondly, if the ear is actively discharging, scanty amount is discharging and suddenly is stopped, then it should be evaluated, as it may now progress inside and may cause complication. So the discharge will be scanty, it will be thick and mucopurulent. The most important thing is that it is very foul smelling. The foul smell is due to bone destruction through enzymes, and there is a very peculiar smell of Atticoantral disease. The discharge may sometimes be blood stained, but it is usually painless. If pain present in tubertympanic, we see that the pain is usually due to otitis externa, but in these conditions the pain is usually referring towards the complication. Hearing loss is usually and commonly is of conductive type, but in long-standing cases due to the toxins of the enzymes also, and if it is affecting the inner ear, the sensorineural element may also be present. So in such cases it will be of mixed deafness. Sometimes what happens as Cholestatoma, there is a term called Cholestatoma hearers. What is this? That because the Cholestatoma, it erodes the ossicles, but patient may not complain of too much hearing loss, as the ossicles, though they have been destroyed or necrosed, but this Cholestatoma, it is sitting there at the place of the ossicles and help in conduction of the sound. Okay, so these are Cholestatoma hearers. In such cases, once the Cholestatoma is removed, so the patient's hearing become worse. So you have to counsel this before the surgery to the patient, that your hearing may get worse after the surgery if the mass is there in the middle ear. Bleeding can occur. It may be fresh blood or it may be blood stain discharge. It may occur due to the granulations or the polyp once they are handled or cleaned. So it is very important to see, to be very careful while cleaning, and one should not put the cotton sticks inside the ear, as it may damage further. Signs. On examination, the classic sign of Cholestatoma is an attic crust. Okay, attic crust. You see, if you just look at the ear in this picture, you may not see too much problem in it, and you may label it as a normal ear, that yeah, a small piece of wax or crust is there, but it may not be a problem. But this small piece, it may just be a door behind a big room. Okay, if you remove this crust, then you will be able to see a big room behind it. So this is a brown flake of this attic crust. It is a brown flake of dried skin in the upper part of the eardrum. You see, this is not the place for any crust or wax here. So whenever you find any crust, wax in this region, it needs to be cleaned and evaluated. Then you may see a perforation behind it, or in this region, or posterior-superior region. This is a posterior-superior part. Okay, so here a marginal perforation may exist, or there may be an attic perforation. If you remove this, then there will be a perforation here. And if you watch carefully, this is the Cholestatoma mass. The cholestatoma is there behind this, and it is hanging down into the middle ear, and here the ossicle, it becomes prominent, and it may have eroded the incus. This is the stapes structure which is visible. So you may find one or two findings or findings in one patient. So a perforation is there. You may just able to visualize a retraction pocket in attic. Even a clean retraction pocket in attic, it should be evaluated and it should be followed up regularly. Or there may be a frank cholestatoma. Big cholestatoma may also be visible. Polyp may also be visible. Granulation tissue may be visible. And the tuning fork test need to be done in examination, okay, and they will show the conductive hearing loss more commonly. The Raynaud's will be negative and the Weber will be lateralized to the diseased ear. So if we see this picture, you see this is the retraction pocket which is starting to appear in the attic region. Retraction pockets, it has different stages. So this appears to be stage 1, when the retraction pocket, it is starting to occur, but it has not come in contact with the incus. So any flakes or keratin debris or the cholestatoma, in such cases they can be regularly suctioned and cleared out under microscope. So these are those cases in which patient can be managed with regular follow-ups and cleaning under microscope without undergoing the surgery. In this picture now, the retraction pocket, it has grown deeper. So, but still the middle ear mucosa looks normal, but in such cases it becomes more difficult now to clear out the cholestatoma or pearly white flakes of cholestatoma through this hole, as it may have grown deeper inside, which may not be visible with naked eye but on microscopic examination. So it's important to identify which case needs to be operation, because there is very limited role of OPD management in retraction pockets, especially stage 1 is the one which can be done like this. If we visualize this picture, you see osteitis due to cholestatoma frequently results in formation of granulation tissue. This is the granulation tissue, okay, from the adjoining bone. So the osteitis of the bone secondary to the cholestatoma, it will lead to formation of granulation tissue, meaning granulation tissue and the cholestatoma can coexist and they can be exist as a separate entity. In this picture you see, you can clearly visualize the cholestatomatous mass and the sac which is extending down into the mesotympanum and the posteriorly also towards the mastoid. So it is eroding everything with congestion. Investigations: how to investigate a case of cholesteatoma or the atticoantral disease. You should be very particular in this, that cholesteatoma is not a separate disease or diagnosis. As already mentioned, it is basically the pathology of atticoantral disease. Okay, many students, they just mention cholesteatoma, a separate disease. When writing the differentials, they write Atticoantral CSOM, cholesteatoma. No, it's one in the same thing. If you have to write cholesteatoma, you have to mention it Atticoantral CSOM and in brackets cholesteatoma. So cholesteatoma is same as atticoantral disease. So first of all, there will be ear swab for CS, examination under microscope. Why it is written examination under microscope? First, because the best way is to check the patient under microscope, do suctioning and take swab from around the perforation margins. Okay, so you do the examination under microscope, then take the ear swab for CS. For taking the swab, it is important that patient should not be on any antibiotics for at least 4-5 days. Then patient should undergo proton audiometry and CT scan of temporal bone. If cholesteatoma is suspected or granulations are there, then CT scan temporal bone should be carried out. X-ray mastoid, the role, usually the finding will be by either it is tuber-tympanic or atticoantral, it just shows clouding of the mastoid air cells. Yes, the role of X-ray is now limited to see the size of the mastoid cavity, as it will help us during the operation. A very good X-rays, a very fine X-ray can show cholestatoma mass as well. So if we see this picture, the patient is comfortably lying in the reclining seat, and the doctor is examining in the microscope, doing the suction and cleaning. Okay, she can manipulate or move the ear speculum. The ear speculum is not visible, but it is inside. So what is best done is to do suction cleaning, then take a ear swab around the perforation margins or from the deep meatus, and then do the rest of the suctioning. Okay, and properly examining inside. This is the X-ray mastoid. These are the teeth. This black hole is the identification point for the external auditory canal, and behind this is the mastoid antrum. These are the boundaries. This is the Tagman wall, and this is the sinus plate, Tagman plate and the sinus plate, and this all is the mastoid antrum. Here there is sclerosis, and there are some pneumatized cells. Okay, but this can also be because there is black shadow there, then this may appear as a cholestatoma mass or sac. It is smoothly round. This is the CT scan of the temporal bone. This is the external auditory canal. This is the middle ear, and this is the cholestatoma sac in the mastoid antrum. Treatment. There is no medical curative treatment. Yes, medicines will be prescribed for the time being when the patient presents to us, but it is not curative. It can delay the consequences of the disease. The definitive treatment is only surgery. So surgery has to be carried out whenever an atticoantral disease is identified. The minimum treatment for atticoantral disease or atticoantral cholestatoma is a canal wall down mastoidectomy. So we have to be sure what are the aims of surgery, why we are offering surgery to the patient. The main aim of surgery is to make the ear safe. And how we achieve this? By eliminating the cholestatoma or the granulations or whatever the disease there, thus reducing the risk of complications. If we don't treat it surgically, then it will expand and can cause complications, may enter into the brain, and ultimately lead to death of the patient. Other minor aims can be to conserve the residual hearing, whatever hearing is left, to conserve that and preventing further damage by the cholestatoma, and in some cases to improve the hearing if and when possible. It is not achievable in every case, but it's important to properly counsel the patient that our main aim is not to make the ear dry or to improve the hearing, but to remove the disease, so to prevent the spread of the disease and complication. So it's very important. Conservative treatment. Yes, a conservative treatment can be given, but it has very limited role, especially in cholestatoma. It can be tried in selective cases, as I already mentioned in the picture, in which their small cholestatomatous mass is visible in a small retraction pocket. You see small and easily accessible cholestatoma in the retraction pocket. So we do regular suction and cleaning under operating microscope, and it has to be followed up monthly to see if it is progressing or not progressing. Because if it is progressing, then definitely this patient needs surgical procedure, and if it is not progressing, then regular suctioning will be enough for him. Periodic checkups and repeated suction clearance are essential in such cases. Then in elderly patients with other comorbids, patients unfit for general anesthesia, patient refusing surgery, these are the conditions in which you can offer conservative treatment. Other methods is the oral toileting. You have to clean the ear of any discharge, debris, white flakes, whatever. And the most important precaution for any CSOM is to keep the ear dry. Patient has to use the earplugs or the cotton dipped in oil, squeezed, and then put in the ear whenever he is taking bath. Surgical treatment. There are two main procedures of surgery, which are the canal wall up and canal wall down procedure. The minimum surgery for atticoantral disease is the canal wall down procedure. Canal wall up has very limited indications, but not for atticoantral disease. The minimum surgery for atticoantral is canal wall down, in this the mastoid cavity, it is opens up into the external auditory canal, meaning the external auditory canal, the mastoid antrum, and the middle ear, they become one whole large cavity, and patient can be followed up and examined in the OPD after the surgery. The disease, it is fully exteriorized. There are further some procedures in canal wall down procedures. The mainly performed procedures can be atticotomy, atticoantrostomy, modified radical mastoidectomy, and radical mastoidectomy. Although radical mastoidectomy has no very limited indications, it is no longer performed routinely. The routinely done procedure is modified radical mastoidectomy. So we look at this picture. Still, this is the surgical procedure going on, but till this stage, this is the cortical mastoidectomy. Why? Because external auditory canal, this is external auditory canal, this is mastoid antrum. They are separate at the moment. As I already mentioned, in modified radical mastoidectomy, this all area becomes one single cavity, but now they are separated by posterior canal wall. So what we do more, this is the cortical, but what we do more to make it a modified radical mastoidectomy, we have to remove this posterior canal wall. We drill this out till the facial canal. So this external auditory canal, the middle ear, and this antrum, it all become one single cavity. If you further, as shown in the X-ray, this is the tegmen plate and this is the sinus plate. Okay, so we have to drill in a way. These are the boundaries of the drilling. We cannot go beyond this. The gastric ridge, the lower boundary is sigmoid sinus, sigmoid plate, tegmen plate, because above this will become dura. So we have to be very careful. So this is although the post-op scar, but this is the basically the incision mark or incision line for the mastoid exploration. This is a post-oral incision just behind the post-oral groove, and then we separate the skin and elevate the mucoperiosteum and start our drilling. And then this is the large cholestatoma and cholestatoma sac, which is removed. So now we will see the difference between the tubulotympanic and atticoantral type of chronic suppurative otitis media. The discharge in tubulotympanic will be profuse, mucoid, and odorless, while in atticoantral it will be scanty, purulent, foul smelling. Perforation will be central in tubular TT, and it will be in attic or marginal in unsafe type. Granulations are very uncommon in tubulotympanic but commonly seen in atticoantral. The polyp will be smooth and pale and edematous in tubulotympanic, while it will be red, fleshy, maybe irregular in atticoantral. Claustratoma, yes, it is only present in the atticoantral type of disease while absent in tubulotympanic. The rate of complications is very rare in tubulotympanic, while the intracranial complications, they are absent in tubulotympanic. While both the complications, if claustratoma or granulations are there and not treated timely, it will lead to complications. So complications are common. Audiogram may show mild to moderate conductive deafness, while in atticoantral, sensorineural element may also prevail, leading to mixed hearing loss also, but commonly again there will also be a conductive deafness. There are certain features which indicate complications. I mean, how we can know that the patient is starting developing complications. So we have to be careful in history to know about these symptoms. If the patient started developing pain and on examination there is no obvious congestion or no swelling in the external aortic canal or the middle ear. So patient having vertigo, persistent headache, facial weakness, may have fever, nausea or vomiting, irritability with neck rigidity, double vision, diplopia, unable to maintain gait, ataxia, or there is abscess around the ear. So any patient with sudden onset of severe deafness can be due to damage to the inner ear. A paralyzed face could be due to the disease affecting the facial nerve, but paralyzed face with history of ear discharge. That is also important. Otherwise, if a paralyzed face, like it can be just a Bell's palsy, so we have to differentiate that it's not a Bell's palsy, but due to the Cholestatoma, the complication is arising. Or other presenting features like patient may have meningitis, neck stiffness, severe headache, photophobia, etc., etc. So any particular symptoms of the complications may be there. Now tubercular otitis media. In most cases, the infection is secondary to pulmonary tuberculosis. Infection reaches the middle ear through eustachian tube. Sometimes it may be blood-borne due to from tubercular focus in the lungs, tonsils, cervical or mesenteric lymph nodes. It is mostly seen in children and young adults. Pathology. The process is slow and insidious. Tubercles, they may appear in the submucosal layer of the middle ear cleft, which may caseate. There is painless necrosis of the tympanic membrane. Multiple perforations may form which coalesce to form a large single perforation. Middle ear and mastoid can get filled up with pale granulations, and caries of the bones and ossicles may occur, leading to complications. Clinical features. There will be painless ear discharge. However, discharge may be found swelling often due to bone destruction. Perforation, as already mentioned, there are multiple perforations, 2 to 3 in pars tensa, which coalesce later on to form a large single perforation. There will be severe hearing loss, which is most commonly of conductive variety, but this hearing loss will be out of proportion to the symptoms. However, sensorineural component may occur due to involvement of the labyrinth. Then granulations may be seen, and facial paralysis can also be there, which can come unexpectedly. Diagnosis. So blood CBC and ESR, raised ESR will give suspicion. Then ear swab for culture and sensitivity of the discharge needs to be done to check for the tubercle bacilli. Histopathological examination of the granulations. X-ray chest, as it is always secondary, usually secondary to the pulmonary TB. And presently, DNA probe and PCR from the ear discharge, it can give early diagnosis. So treatment, the first and most important is the systemic anti-tubercular therapy for the requirements in consultation with the medical department. Then local treatment will be limited not only just to the oral toileting but also to the topical antibiotic drops to counter the local infection. Mastoid surgery is only indicated for complications. Healing in tubercular cases will be delayed, and wound breakdown with fistula formation are common. Thank you.